For those, oh, thank you, thank you. For those of you that do not know me, I am Sarah Reeves. I'm an assistant professor here in CHEAR, and I will be facilitating the CHEAR seminars for this year. So welcome to the first official CHEAR seminar of the year. To orient you to the fact that we seem to have things often on Tuesdays, we have method seminars also and CHEAR seminars, and you're all welcome to attend any and all that you would like to. So I have the privilege today to introduce Joyce Molinar, and Joyce is a visiting scholar here at CHEAR. She's been here about a month, and she's here from the National Institute for Public Health in Leiden University in the Netherlands. And she completed her education in health sciences and global health, and since then has worked as a researcher in maternity care and related fields to improve the health and well-being of current parents, future parents, and children. I will let her describe more of what her research focuses on in her primary project, but it's been great to host you here at CHEAR for the last month, and we're looking forward to hearing about your dissertation. Thanks.
Thank you so much, Sarah. So welcome everyone to this presentation about monitoring the Dutch first 1,000 days approach. So my name is Joyce Molinar. I work in the Netherlands. Thank you for the great introduction already. I'm a PhD student, and I was very lucky to be here as a visiting scholar. So thank you all once again for showing me around a bit here and telling you about your interesting work. My PhD thesis is focused on providing insight into the adoption of the Dutch first 1,000 days approach, which we call the Dutch Solid Start program in the Netherlands. And during today's presentation, I will first give you more insight into the importance of the first 1,000 days. I will then continue with describing the Dutch first 1,000 days program, as well as how we monitor the program. And I will then continue providing more insight into two topics of my PhD thesis that are vulnerability, as well as the experiences with the Solid Start program with specific focus to collaboration. Having a pop-up here about the recording. Okay. Oh, wait. Yes. Okay, so a good start in life is of fundamental importance for our further development and health. During the first 1,000 days, which is roughly the period from conception to a child's second birthday, the foundations for later optimal health and well-being are established. Your organs and your immune system develop, you learn how to talk, walk, drink, and eat. The speed of your development is the highest compared to any other period in your life, and it's also the period in which the ability to adapt to environmental exposures and experiences is highest. So although of course other experiences during your whole life can still influence health and well-being, the period, the first 1,000 days, during those first 1,000 days, the foundations are laid and it has lifelong effects. Some of the concepts that is sometimes used within the first 1,000 days is the developmental origins of health and disease concept that explains that many also chronic conditions have their origins in early life. So for example, asthma, diabetes, hypertension, and many cardiovascular diseases as well. And one of the, sorry?
Don't forget the brain.
Exactly, the brain as well. Yeah, and one of the mechanisms that is described is epigenetic programming, which explains how during critical times of development, some external exposures can program the bodily structures or functions to the environment it will probably face in the future. So once again, it shows the importance of the first 1,000 days. The first 1,000 days are also often considered a window of opportunity to reduce health inequities. Those can be described as unfair, preventable, and unnecessary differences between different groups or social groups relating to, for example, gender, ethnicity, income, educational level. And we also know that the word health disparities is also often used to refer to those health inequities. And there's now also a large body of evidence that provides information on how not only the genetic, biological, or medical factors influence health, but it's more related to the social, economic, cultural, and environmental factors that are described as the social determinants of health by the World Health Organization as well. The life course approach provides more insight in how health inequities can have its origin in early life and can also accumulate over life. And it provides a way to stimulate action focused on these first 1,000 days. This is a framework that we often use in our studies that shows how health and development of children, presented in the middle purple circle, is influenced by many different factors. This is a framework from the National Academies of Science, Engineering and Medicine called the Vibrant and Healthy Kids Framework. So within the direct environment of the child are the direct influences such as family cohesion or caregiver well-being, presented in the dark pink layer. And those are influenced by the more social, economical, and environmental factors, social determinants of health. Here as shown as the healthy living conditions, for example, as well as early care and education. And then we also have the more socioeconomic and political drivers in the outer gray layer that provide or that drive opportunities among the population as well. And there are all kinds of factors that can act either as risk factors to vulnerability or health, as well as protective factors on all these levels throughout the life course. And health is not static. So as you can see here in this framework, which shows the health development of two individuals, there are different exposures and experiences that can still influence life, health and development during our life. So beside equity considerations to focus on those first 1,000 days, economic considerations can be made and be important as well. So the Nobel Prize winning economist James Heckman, he showed that the highest return on investment can be made by focusing on early life, because then the beneficial effects can be enjoyed for longer and they will also have an accumulating effect during the life course. So once again, this shows the importance. In 2018, the Dutch Ministry of Health, Welfare and Sport implemented the Dutch first 1,000 days approach. We call it het actieprogramma Kansrijke Start. That can be translated as the National Action Program Solid Start. It consists of a comprehensive population-based and upstream strategy focused on early life in order to prevent problems to widen and help equities to grow. It has 3 pillars. It's focused on the period before pregnancy, during pregnancy, and after birth. And at the start of the program, there were several aims set that can be summarized as preventing unwanted pregnancies, preparing parents better for a healthy pregnancy, identifying medical and social problems sooner, both during pregnancy as well as in early life after birth, and providing tailored support for parents and children in vulnerable situations. The program was implemented in 2018, or the initial program, and starting from last year, we also have a follow-up approach. So the Ministry of Health implemented policy measures that are really have a preventive focus. Mainly, they aim to improve the collaboration between the medical and social care sector, as many of the health issues are related to social determinants. And the program has a specific focus to families in vulnerable situations. Municipalities are in the lead to create local coalitions of all stakeholders from the medical and social care sector. Those can be, for example, midwives, obstetricians, maternity care assistants, but also social workers, as well as debt counselors, municipal officials, all kinds of different organizations and healthcare providers. So it's a national program, but it really aims to stimulate collaboration on a local level. And the idea is that the municipalities start an approach based on their local challenges, the local data, the local issues that they are having there, and the existing networks they already have. They are supported by different measures. So they received a financial grant from the Ministry of Health to really start the coalition, so to organize an initial meeting, for example. They were provided with a list of possible interventions, an analysis tool to map the current and the envisioned situation. And they also received help from VAROS, which is the Dutch Expertise Center on Health Disparities, to start building and strengthening their local coalition. At the Ministry of Health, we were commissioned to monitor the program since 2019. And we are doing so by both qualitative and quantitative research methods. We started on a national level, but we also started a local support program focused on monitoring in 2021 as well. And on this slide, you see some of the reports and fact sheets we published that are publicly available, but mainly shared with Ministry of Health. So for the national level, we have different quantitative and qualitative research elements. So first we conducted a Delphi study with experts from practice, policy, and research to make a list of 15 indicators to monitor the program. And within this list of indicators, there were both process indicators as well as outcomes. So processes relate to, for example, how many municipalities or the percentage of municipalities that have actually started a local coalition or that made plans or kind of action plan. And outcome indicators can be, for example, the percentage of children with overweight at the age of 2, or the percentage of children being born prematurely or with a low birth weight. So altogether, they provide insight in both the implementation of the program and the process thereof, as well as the health outcomes and the underlying determinants that would define health for parents and children. We have different data sources that we use in quantifying those indicators on a yearly basis. First, we use our nationwide population-based data infrastructure that is called DIPER, Data Infrastructure for Parents and Children. I will explain more about that in a minute. We also administer a questionnaire among all Dutch municipalities every year, and we inquire national organizations that are involved in implementing interventions, as well as youth healthcare organizations to provide us with data. The qualitative part consists of focus group discussions with stakeholders from practice, policy, and research. So those are, for example, healthcare professionals, but also managers, solid start project leaders or advisors, etc. And we conduct interviews with also these stakeholders, but also experts by experiences and clients. And those experts by experiences are mostly women now who have lived experience themselves, but who also learned how to use that, or the shared experiences of many others also, to improve policy and practice. So we use DIPER, Data Infrastructure for Parents and Children. That is a nationwide data source combining actually 3 nationwide data sources on an individual level. So it consists of Perinet, Factis, and Statistics Netherlands mainly. Perinet is the Dutch perinatal registry that collects data on care and health outcomes during pregnancy and childbirth, and provided by midwives, gynecologists, and pediatricians. Then we have Factis that collects claims data under the Dutch Healthcare Insurance Act. So everyone in the Netherlands is obliged to have a standard package of health insurance, and they collect all data around that. So it provides insight into healthcare utilization and costs. And then we use data of Statistics Netherlands, and they collect and publish data on different societal themes, such as income, living environment, education, work, all kind of different elements. We work within the secured environment of Statistics Netherlands, and mostly we use linkage keys or a combination of, or this is just the citizen service number to combine the different elements. So what we lack, which is a huge limitation, is that there's no nationwide data on child development and health. So all children are seen by youth healthcare professionals during the period from 0 till the age of 18. But there's no nationwide registry of that data. So we have around 40 organizations that do collect the data themselves, but they also, there's no nationwide registry. This metro line map kind of thing shows some of the variables we included. So we can prepare study files based on the different research questions we have. It can be focused on either pregnancy level, provide insight into the father of the mother or the child. I will come back in more detail about some of the specific variables that we can include. So some of the results of this yearly monitoring. Here we present the indicator or an overview of the 15 indicators. And as you can see, we have some program-wide indicators. that mostly relate to the municipality starting their coalition. And we have some indicators focused on the 3 periods or the 3 pillars of the program. So before pregnancy, during pregnancy, and after birth. And we would present on a yearly basis the percentages, but also show whether there's progress in the desired direction. As you can see on the right side, there mostly is, indicated by the green dots. So some of the examples are before pregnancy, the municipalities that implemented some kind of intervention, but during pregnancy also how many pregnant women started prenatal care before after the 10th week of pregnancy, and after birth, for example, low birth weight, and premature birth or preterm birth, but also families not utilizing maternity care assistance after the delivery. That is, I think, a specific unique element of the Dutch healthcare system, that women or parents receive care at home for 8 days, postpartum care at home from maternity care assistants to help them start up their life with the baby. So some results in more detail. This map shows the municipalities that requested the Solid Start funds over the years. So you really see an increase of how many municipalities did start with the program. And here you also see the number of municipalities that started a coalition. In total, we have around 340 municipalities in the Netherlands. And at the end of 2022, half of them really had a coalition, and even more were having a coalition in preparation. So they were really focused on implementing Solid Start as well. You cannot really see a gray line here, but on top is a gray line too that presents the municipalities that did not respond to the questionnaire. So there's still some things we, of course, don't know. But then who are involved? It's again a bit small here, but I will explain it a little bit more. So from the medical sector, we see that mostly midwives and maternity care assistants are involved, or maternity care networks or integrated care organizations. Around 50% of the municipalities also include general practitioners as well as obstetricians. Pediatricians are involved in around 40% of the municipalities or the local coalitions. And then we have the psychiatry, obstetrics, and pediatrics department, for example, mental health care, health insurance companies, and some smaller organizations that are involved too. Within the social sector, the main stakeholders that are often involved are youth healthcare, public health services, neighborhood or social care teams, daycare as well, and the Center for Work and Family or social services in general. So what is not presented on this slide is that also 1 in 3 municipalities include experts by experiences or clients or another community-based organization. And the main actors that are missed are often general practitioners, health insurance, and still experts by experience. So municipalities work hard on including them as well within their coalition. This is how we would, for example, present the percentage of prematurity and low birth weight over time, which is decreasing a little bit. And this is how we would present percentage of vulnerability over time. And I wanted to show you the slide, the map on the right as well, because we can also provide insight in what are the percentages on a more local municipality level. And this also helps municipalities to compare it to others and to see on a national level where the most investments are necessary. Besides the national monitoring, we started in 2021 with a support program for.
Can I ask a question? Can you go back one slide?
Yes.
Was the percent for each municipality, is that a percent change or the percent that it was at?
So it was the percent that it was at over the years.
Okay.
2017, 2021, but overall.
Thank you.
Because sometimes the percentages are really small for each year, so now we decided to combine them into.
Thank you.
And are you able to compare the municipalities where you have the program with those that don't?
Yes, so that's actually something we are focused on right now. We aim to provide insight into the early effects of the program. using a difference in differences design. And then we compare municipalities that started with the program really early with municipalities that didn't start at all or very late. So they are starting kind of right now, because at this moment, each municipality receives funds to start some kind of solid start program. So we are working on that, but I cannot provide insight in that so far. Yeah.
So actually, so the idea that some municipalities started early, some didn't even participate at all, makes me wonder what the selection bias is. And I wonder,
Yes.
is it the case that the heavily populated cities in North and South Holland all participate in the rural areas outside of those regions?
Yes. So what you see is that mainly in the beginning, also the funds were only open to municipalities that already had some kind of program focused on reducing health inequities. So there is some bias there. And within our study, trying to identify the early effects, we try to integrate that idea as well. So we try to compare municipalities that are about the same, have about the same population, that are comparable in terms of vulnerability, that are comparable in terms of how more of the city or more on the countryside there they are. So we try to integrate all kind of things in order to ensure that we can compare the municipalities well. And that also probably means that some municipalities cannot join in that study because they are not comparable to others. They are really like the main cities, for example, or the really, really small cities.
Is there, I also wonder, is there any threat of politicization of a program like this, a large scale population health surveillance program? And I specifically, I'm wondering with the Liberal Prime Minister Rutte being, he's going to step down, and
Yes.
if he's replaced with a conservative government, could that be a threat to the funding of this?
So we noticed so far that it's not really dependent on political color, I would say. So many of the political parties in the Netherlands are in favor of this program, since it's so much focused on we have to focus on prevention, we have to start early. And well, so now we also noticed that there will be a new a new government soon. But the Ministry of Health and the people we collaborate with are not afraid that it will stop the program from continuing. So there's now actually structural funding available for the municipalities until further notice. So we expect that the program can still continue. Yeah.
One of the major differences in the ones in the US.
Yeah, so for some programs, there are difficulties, but
Okay.
this one we expect that it can just continue.
The variability, vulnerability, is that an aggregate?
Yeah, I will get into more detail on vulnerability later. Yeah, so maybe let's save your questions on that point. I will discuss that later. So beside the national monitoring level, we also implemented the local level support program to support municipalities in coalition in monitoring their local approach. We called that the Learning Local Monitor. So let's start because it was really based on trying to improve learning and knowledge sharing, both among as well as within the coalitions. Over the past years, we have organized several learning sessions with 11 coalitions that already started the program really early and also started monitoring very early, so they can share their experiences and challenges and needs in doing so. And based on those challenges and needs, we also organize thematic sessions for everyone, so all municipalities can join those sessions. And that is presented a bit here. So we have the national program and the Learning Local Monitor. We aim to increase mutual learning within and between the coalitions. And in the middle purple one is the learning sessions with the 11 coalitions. And then we organize different thematic sessions, for example, about monitoring collaboration, about how to provide insight into vulnerability and monitor that aspect within the municipality, but also how can we involve experts by experience in monitoring. One of the first needs that were expressed by the coalitions was that they required their own indicator set as well, because they said although the national indicator set is useful to some extent, it does not fully fit our local focus. So we helped them in establishing a set of indicators as well, and we made a website in which they can also access the data for the municipality and compare that to other municipalities or regions as well. So my PhD thesis really forms the scientific basis for the monitor, and I focus on different elements. One of them is vulnerability and how to operationalize that. Those are actually two papers, of which one of them is published and shown on this slide. Then I provide insight into the experiences with the Solid Start program with a specific focus to collaboration. I also explain the development of the local indicator set, and the next one, which I just discussed, we are now focusing on finding out whether we can identify some early effects of the program using a difference in differences design. And I would like to tell you more about the first two elements, so vulnerability as well as experiences with Solid Start in more detail. So to start with vulnerability, there are different definitions used, or at least in the Netherlands. So one would describe vulnerability as some kind of dynamic state that reflects converging effects of a set of interacting and amplifying both personal and environmental factors. Others would describe vulnerability or pregnant vulnerable woman as threatened by physical, psychological, cognitive, and social risk factors in combination with a lack of adequate support or adequate coping skills. So in this paper, there was still a reference to a vulnerable pregnant woman, which now has changed to women or parents or children in vulnerable situations, because the idea is that it's not static, but it can also change. And everyone can be vulnerable at one point. Van der Meer, they described vulnerability arising from an imbalance between risk factors and protective factors. And within their study, they also make a difference between a highly vulnerable situation, which means that there are some immediate risk factors. So for example, not having a house to live in, as well as vulnerability in general, that is because of a combination of risk factors and protective factors. And then Piscool will describe vulnerability that it can describe during pregnancy, birth, and the postnatal period by three main attributes. And whether a certain threat really influences vulnerability depends on whether there are some repair mechanisms available, so warm supporting relationships, for example, or a good social stable network, as well as barriers that might be there to access care. So for example, stigmatization. What those definitions seem to have in common is that they would all refer to those at risk of poor health or well-being, or poor access to health or well-being. They would describe vulnerability as some kind of dynamic, contextualized, and complex process in which different levels or life domains are involved. And they would say that it's an interplay of risk and protective factors, but not a simple equation, but still risk factors can act as increasing vulnerability, such as, for example, unemployment or living in a more deprived neighborhood, or a lack of material resources or unfavorable lifestyle factors. But then on the other hand, there can be protective factors that reduce or prevent vulnerability as well. Those can be, for example, so the stable social network, or a stable relationship, or other supporting systems. We did, however, when reviewing the literature, find some gaps. So most studies would describe the relation between certain predefined risk factors or single risk factors and outcomes, and they would provide limited insight into the coexistence of risk factors or the coexistence of both risk and protective factors. So that brought us to questions around how to use these definitions to also operationalize vulnerability in order to use it for population level monitoring, using the nationwide data that we had available. So we conducted two studies on this, and the first one aimed to identify classes of vulnerability among pregnant women in the Netherlands using pre-pregnancy data on a wide range of different social risk and protective factors. And we aim to validate these classes against the risk of adverse outcomes for mother and child. We used our data infrastructure Diaper again. We started with compiling a list of what can be possible risk factors or protective factors that are described in literature, conceptual models, or frameworks. And based on that, we looked into what data is available. So when a risk factor would be, for example, poverty, we would have data on low income or debts and financial issues available. We also used a specific data set, the Public Health Monitor, which is a survey that is administered every 4 years among a large and varying sample of the Dutch population. Around 500,000 people participate. Of course, not all of them were pregnant after, got pregnant after. So, but still, it provides a lot of information about experienced health and lifestyle factors that are also really important in vulnerability. So that's why we included this data source as well. Here's a list of the different indicators that or the different variables that we included, organized in 9 themes. So we had information on individual characteristics, also socioeconomic characteristics, lifestyle factors, mainly from the Public Health Monitor, some information about household composition, self-reported health, more insight into healthcare expenditures and utilization, psychosocial characteristics, life events, and living conditions. And often we would categorize these variables into either yes or no, or high or low, or sometimes we had 3 different categories. So for example, is your experienced health good, negative, or neutral?
There are a lot of variables here, and your first slide talked about the Barker hypothesis, prenatal origins of adult disease. So the focus is on pregnancy and the status of the child when born going forward.
Yeah.
What does, I'm just looking at the lifestyle factors. You have smoking, excessive alcohol, whatever. I mean, smoking is a strong predictor of lower birth weight.
Mm-hmm.
Alcohol has other effects directly on the nervous system, not only. And I'm just wondering, there's a lot of focus on the mom here, but what's known about the proximal predictors of low birth weight?
Yes.
I mean,
So
couldn't you compress it?
Yeah, so we focused here on mostly the social determinants, so not the medical elements. And we looked into what are the pre-pregnancy data of women, and didn't include the outcomes of children yet, although
Why?
Because we wanted to validate these classes. Also, we wanted to provide insight into vulnerability itself without yet starting with the outcomes. So we wanted to gain insight into what kind of risk and protective factors most often co-occur, or what kind of insight we can provide in different groups of women without starting from the negative outcomes themselves. So that is also often done, that we would want to predict who will have a premature birth, for example, or things like that. But we started with the data themselves, just to provide insight into what kind of things do we see here.
Joyce, can I ask a clarifying question?
Yes.
Are you kind of looking for predictors as opposed to causal pathways then? Like you're not really thinking about like, these are direct causal lines, but more just predictors of these subgroups?
Well, it's more of, we started with, we didn't, so combining it with the outcomes for the second step. Only validated.
Sure.
But we really want it to be a data-driven study.
Yeah.
Starting from what kind of risk factors or protective factors can be there already before pregnancy, and not connected yet to the outcomes.
Great.
So, yeah.
Just to finish my thought, so this is a big program, it's nationwide. Whatever the investment financial, it's probably significant. And the investment is going to probably be time limited unless one can demonstrate some degree of effectiveness.
Yes.
And to be cynical about it, I think if the goal is to have children that are born healthy, as healthy as possible.
Yes.
This seems like a diversion into a research agenda, which is interesting, but not predominantly focused on the issue of low birth weight prematurity,
Mhm.
which predicts, I mean, it's sort of like people have been working on this particular topic
Yes,
for a lot of time.
Yes.
And do we have to go through the exercise if
Yeah.
that's what we're interested
yeah.
in?
Well, yeah, I do. Maybe some of the things I will discuss will provide more insight into that as well. But I do think that it's relevant to also gain insight into the concept of vulnerability in general, and then next we look into how does that influence outcomes and can we, yeah. But I think some of the elements will be discussed during the presentation as well. But thank you for your comments. It's really important to reflect on the things we do. So we have this list of 42 variables, which we then also looked into the site. So we made a study population consisting of all women who participated in the public health monitor prior to their pregnancy. So the pregnancy started in 2017 or 2018, and they also gave birth during that period. So in total, we had more than 4,000 women that participated in this study. So it was a data-driven study. We started with those 4,000 women, those 42 variables, and we conducted a latent class analysis, which is an analysis that aims to provide structure in the data and classify individuals based on their shared risk factors or protective factors to vulnerability. Beforehand, you don't specify the number of classes or the sizes thereof because it's a data-driven technique. Based on different statistical measures, we found out that we found 5 different clusters, of which one of them can be described by mainly risk factors to vulnerability, 3 others by risk factors to vulnerability in one specific domain, and 1 with mostly protective factors to vulnerability. So in the first category, we named the categories after the most prevalent risk factors. And the first one was called multidimensional vulnerability, because these women showed risk factors to different domains. They, for example, more often didn't have social benefits or no income. They would have 1 or more long-term illnesses. They would perceive their health as negative or more often lonely. So we saw risk factors in different health domains. Those risk factors are presented in black on this slide, and the possible protective factors are presented in gray. So we had 3 groups that were named high care utilization, socioeconomic vulnerability, and psychosocial vulnerability. And those women mostly had risk factors within either high healthcare expenditures, or they had more socioeconomic risk factors or more psychosocial risk factors. On the other hand, they also shared protective factors such as a higher educational level, positively experienced health, etc. And on the right side, that was the largest group. We had the healthy and socioeconomically stable women, or we called the group this way because they had mostly protective factors to vulnerability. They considered their health as positive, that often did not feel lonely at a higher educational level, etc. This classification is also shown on this slide, in which you see the average proportion of women experiencing risks that is combined for the different themes that we discussed. So the blue line shows a higher percentage on basically all the different themes. And for the other ones, you will see that depending on the risk factors, so for example, the gray line has more risk factors related to socioeconomic characteristics only. So that was the socioeconomic vulnerability class. And you will see some percentages here, but we were not sure about the percentage in the general population, considering that this was also a specific group. We combined it with the health monitor, and mostly, although they really aim to provide a more representative sample of the population, we'll see that more often people that are higher educated or have a higher income would participate. So we have a not fully representative sample here. So then we check the relation with adverse outcomes, just to validate our classes. We looked into outcomes for both mothers during pregnancy as well as for children. So for example, preterm birth, low birth weight was again included, cesarean section as well. And we found out that multidimensional vulnerability more often had adverse outcomes compared to vulnerability within one domain or compared to no vulnerability. And this shows again the importance of the coexistence or clustering of different risk factors. And we did find also that women with socioeconomic vulnerability did not necessarily experience worse outcomes, although that is often described like that in the literature. And we think that there might be an influence of protective factors as buffering mechanisms, or that low socioeconomic status in itself is not necessarily a risk factor unless it coincides with other risk factors or hardships. Lastly, we saw a difference in care utilization patterns between the classes. Those with higher vulnerability levels and higher healthcare needs, but less access or lower quality of care. That is also described like that in the literature. Some of the implications and next steps. So we would consider that screening instruments. So screening instruments are now more often used in daily care for midwives or obstetricians to identify not only medical factors, but also risk factors. And we do think that they can also benefit from including both risk as well as protective factors and looking at the factors that are most prevalent in the different classes. It also provides more insight or gives a need to have greater consciousness among service providers regarding the complexity of vulnerability. And there's a need to provide person-centered care and support there. And we think that focusing on vulnerability does not only require individual level interventions focused on the risk factors for the separate groups, but also systemic level change as the policies and laws and regulations also often influence these risk factors themselves. But we were also wondering, based on this study, would it be possible to also predict population level vulnerability using only nationwide routinely collected data? Because that data is available to everyone, doesn't require extra data collection, etc. But then we couldn't use self-reported data. So that was the start of our second research into vulnerability, in which we aim to assess the feasibility of predicting multidimensional vulnerability at population level using solely routinely collected data. So the data that was available to everyone. And then we also aim to explore can the model be improved by adding self-reported data, and what are the key predictors to vulnerability. And these insights can also be used in providing insight in what is the percentage of vulnerability on a national level and what are the differences between municipalities in order to provide insight in what is the size of the program, are there spatial differences, and what are trends. So we use the same data as before, and we conducted different data science technologies, including random forest, XGBoost, and also regression as sensitivity analysis. Some of the results were that using only routinely collected data to predict vulnerability was feasible, but there was also some misclassification. So some women were missed and others were included. Well, they were, according to our previous model, not included in the multidimensional vulnerability group. We can use these outcomes to monitor vulnerability at population level. That's what we think, at least. We wouldn't use it for individual level predictions because of the more contextualized and personal needs there. But it does provide some insight into the prevalence trends and spatial differences. As can be seen on the right, those are copied from some slides before. So we'll use these insights into monitoring directly. We did find also that adding self-reported data improved predictions. So they are really important, and also among the key predictors were many variables related to self-reported health as well as the socioeconomic characteristics. So we would say that asking for those self-reported health outcomes or self-reported health status within daily practice is really important and should be included in screening instruments for vulnerability or just regular conversations with clients. And we can also use this information maybe in the future if it is collected routinely to improve our predictions at national level as well. Some next steps, we aim to include the woman's partner and or father and the wider social network as well. And we want to take into account the dynamics around pregnancy. So we now looked into mostly data prior to pregnancy, but vulnerability can exist prior to pregnancy, but also arise or change during pregnancy, childbirth, and after birth, of course. So that's where we work on right now as well. Then I would like to continue to the final topic of today, which is the experiences with Solid Start and specifically the collaboration. So we started from the start of the program with public discussions and interviews to collect data on how stakeholders experience the program. So it's really necessary and important to look into what are the facilitators, what are the barriers, what are the needs to further improve the program. And we also identified a gap in literature that most studies focus on either collaboration within a single domain, so the medical sector or the social care sector, or a specific time frame. So it would be focused on pregnancy only or after birth only. And now we aim to focus on both collaboration, medical and social care sector, as well as the full period of the first 1,000 days. And the research aim was to describe the implementation of Solid Start during here the first 3 years of the program. And the research questions that were set were, to what extent is the program implemented within municipalities? That's something we already discussed. So we saw an increase in coalitions and the coalitions that made plans or objectives and things like that. And the second one is, what are the experiences of stakeholders with the implementation of the Solid Start program and cross-sectoral collaboration? And I would like to go deeper into that aspect. So we conducted focus group discussions and interviews with specific stakeholders, representative of care and support organizations, including both managers, but also healthcare providers themselves. We included Solid Start project leaders or advisors and other municipal officials that are working on Solid Start. We included researchers and representatives of knowledge institutes and national professional associations. So for example, those focused on midwives or obstetricians or pediatricians. And we included clients and experts by experience, mainly in interviews. We used the rainbow model of integrated care to organize our coding and organize our results. So this model shows 6 different dimensions representing integrated care. It starts with clinical integration in the middle, which refers to the collaboration between the healthcare provider and the client. And then it refers to the collaboration between professionals and organizations, referred to as professional integration and organizational integration. And on the more macro level, we have systemic integration that refers to more policies and laws that also influence collaboration. And those different domains are linked and enabled through both functional integration, that can be, for example, information system or other structural functions, as well as normative integration that relate to, for example, the more softer aspects of collaboration, including shared vision, a culture, more informal collaboration. So some of the results, first, the positive experiences and developments. We found that stakeholders would appreciate the program as it increased the sense of urgency of investing in the first 1,000 days. It also helped professionals from different backgrounds to get to know each other. Most often these different professionals have a different education system, different structures, different cultures, etc. But this program really helped them to get to know each other a little bit better, and based on that also start implementing more collaborative agreements on cross-sectoral care provision. So they would together make guidelines, protocols, and interventions. And of course, they already started this process, but based on Solid Start, they could do more. And some helpful elements were that they really had the idea of having this shared societal goal, and that often now there was an active coordinator as a driving force to start making those collaborations. They appreciated the program structure. So it was a national program and it really had governmental stewardship towards more collaboration and improving the first 1,000 days. But it also at the same time had a really strong local focus. So it meant that the municipalities could really focus on their local issues, base their work on their local existing networks, etc. And the stakeholders appreciated the possibilities for learning and knowledge sharing that were provided during the implementation of the program. However, they would also say that Solid Start is not yet fully incorporated into all professionals' everyday practice. So that should challenge that the idea does not only stay on more governmental or policy tables, but really goes into daily care. They aim to further transcend domain perceptions, cultural differences, and the fragmentation. And they also emphasize the importance of ensuring the program's sustainability. So we need to continue focus on this, and therefore we also require sustainable funding, supportive regulations, responsiveness to stakeholder needs, ongoing knowledge development, and client involvement. Because some of these elements were really expressed as a challenge now. So although the municipalities would receive some kind of money to start with the program, this was only limited and a one-time thing by that time. So they would also require more funds to continue on working on this. And by this time, they do receive some additional funds from the Ministry of Health to continue. So that's a good thing. But they would also tell us that still it's sometimes difficult to fund preventive measures, because is it the responsibility of the municipalities, the insurance companies, or who are responsible for that? And that then regarding the supportive regulations, they stated that sometimes there were laws and regulations that did not facilitate collaboration. So, for example, youth healthcare providers would be responsible mainly for the health of children during the age of 0 till 18, and that does not include pregnancy. So their involvement sometimes in this first 1,000 days program was limited too, because they wanted to focus on their core activities. As well as who is responsible for preconception care or starting a healthy pregnancy. Maybe midwives are, but they mostly see women when they are already pregnant. So there are some things over there, and you will see that, or we saw that most common barriers and needs for collaboration were more related to the systemic integration at macro level. Some concluding notes and way forward. So we concluded that the Dutch first 1,000, or we saw that the Dutch first 1,000 days program, Solid Start, really created a movement towards more integrated and population health-based care and support. We saw various incremental changes that supported collaboration for early life without major transformation of systemic structures. But we don't know yet what are the early effects of the program, so we focus on trying to identifying them now as well. There is currently structural political support and annual funding available, as I told you already, and we will also continue monitoring on national and local level with the focus on the early effects now. And we are also interested in, of course, what can we learn from other places. So that's why partly I'm here, and I will also go to Boston Children's Hospital after. In Boston, they also had a first 1,000 days program, so I'm really curious about what the experiences over there are about the implementation of the program and the challenges, the needs, etc. But this was it for now. Thanks for your attention. I'm really curious about any more questions or comments. And I would like to thank you once again for providing me the opportunity to be here over the last 4 weeks. I've really enjoyed my time here as a visiting scholar, and I really hope to come back one day. But this was also a nice way to end my time here. I will leave this morning, first to Toronto and then to Boston later. So thank you.
I have 5 minutes for questions.
I'm wondering if you could, in your diff and diff analysis that you're working on, are you going to look for heterogeneity by the vulnerability clusters that you defined in AIM, your second AIM, the one that does not require self-reported data,
Yes.
right? Is there, because that would make sense to way to, not that you have to tie all your dissertation pieces together, but
Yes.
necessarily, but that would be a nice linkage, right?
That outcome is used as one of the variables that we use to compare the municipalities on. So which municipalities to include in which group or who to compare with whom is based on also the percentage of vulnerability within the municipality. So yes, we include that. Any other questions? Chance?
Yeah, I have some comments regarding the methodologies, because the first papers you have the 42 variables, and I think I didn't see how you classify those things. It seems more arbitrary, since that's this category and that's that.
Yeah.
And I think there's currently the machine learning approach that could do like feature selections to select the most important features that most relate to your outcomes. I
Yes.
think that's probably another approach you could use.
Yes.
I think the second paper you use SG Boost and Lasso approach, I think to compare with maybe logistic regressions and to see the accuracy, something like that. But I think there's maybe less papers that could be do feature selections. And
Yes.
what kind of features that's.
Yeah, I would love to learn more about that. So now we also use random forest to look into the most important predictors. So we looked into the out of bag variable importance for random forest. But if there are other options, I would love to learn more about those too. Yes,
Yeah.
maybe we can exchange them as well.
Yeah.
Yeah. Yes.
Thank you. That was a great presentation and very informative. I was wondering, what are the priorities for the policy in the Netherlands? Like, is there any specific, and I apologize if you may have mentioned that. So what particular things are you trying to improve in the first 1,000 days? Are there any specific outcomes like children obesity or overweight?
Yeah.
And do you have any particular alarming percentages of early infant outcomes like birth outcomes?
Yes.
And also for the inequities, so besides the vulnerability categories, do you have any other types of inequities, like the residence area you might have mentioned about geographical area, like rural versus urban, and any other things you might be interested to look at, like asylum seekers versus nationals, and how these differ, like
Yeah.
how outcomes might differ and
Yes, yeah, good questions. So to start, the program is really aimed to provide as many children the best possible start in life as possible. And it had in the beginning 6 general aims that focused on preventing unwanted or unintended pregnancies, preparing parents better for pregnancy, identifying medical and social problems sooner, as well as providing tailored support for parents and children. So those were the general aims. And we now see within the follow-up program that it's really focused on how to sustain this program and how to really improve that the local coalitions that are made continue to have a good impact and increase the collaboration between the medical and social care sector. And the program is really focused on how can we best also support healthcare professionals in providing care and doing these things on a local level. We don't really have high numbers of certain specific outcomes. I think it was around 20 years ago when there were high numbers of infant mortality also in the Netherlands, and that shocked everyone. So based on that, there was also an increase in how can we improve the collaboration within the medical sector. Is it a good idea that we have so many home births or not? And how can we, I think it's, so in the Netherlands, we also had a lot of home births. It was 30% around 20 years ago, and now it's only 11 or 12%. But I do think that it's a good thing that we would keep this system and provide them and also the opportunity to give birth at home. But there has been a lot of those things going on. So I think based on the low or the higher infant mortality compared to other European or Western countries, a lot of things change towards more collaboration. And this is also in the end one of them, I think, that for the first time not only focuses on the medical field or the social field separately, but really combines it. Yeah. And then I forgot your second question.
Yeah, I think, I don't know, like we're over time probably.
I might go ahead
Oh,
and
yes,
pause
okay,
it.
we can.
Thank you so much, Joyce. That was fantastic. We'd love to hosting you here. There's a link for those in the chat, and then Sam, if you want to pull up the QR code to give Joyce some feedback on her talk, and Joyce will send that to you. Please feel free. I don't think anybody's in the room after, so join if you have more questions. Thanks, Joyce. Safe travels.
Safe travels. Thanks.
Now you get to only Joyce.
Can I stop sharing?
Yes, I gotta go.
Really.
Yeah. That's great. Really, really good. Okay.
There was a lot of talking.
That was a lot of talking.
And I was thinking like, wow, you did it's, I mean, I can get around in Spanish, but I don't think I could do a scientific research presentation in another language.
Yeah.
In a strange
It is
place.
different though, because I think normally I wouldn't, so I would always prepare presentations,
Yeah.
obviously.